speaker is Dr. Shobana, and the topic is a study on hot flushes, Indian perspective. I welcome Dr. Shobana for this talk.
Good afternoon. I thank Bhopal Society for hosting this meeting. The maximum number of delegates in any IMSCON is in Bhopal, I think. And that should be really heartening, because even if that's a meager attendance, at least there are so many people sitting in one hall. In most IMSCONs, there is nobody in the hall except the chairpersons and the speakers. So Bhopal has to be given a, special medal for having so many people in an IMSCON. So this is a study which took me 2-3 years to conduct, and I thought I have to present it somewhere. Incidence of hot flashes in India. None of the participants in the study are here, so I will not be describing them. Next. Okay. When I became the president, I was wondering what I need to have, Jai Hind, I need some Indian study for. 1 minute, one participant is here. Dr. Revati Janki Ram, who gave me the second highest number of people from Madurai. The highest was Seema Sharma, but highest number of, studies were given by Dr. Revati. Thank you, madam. Yeah. So I was wondering what to do now. There is already a study on what is the median age of menopause in India. So to have Indian study, when you go somewhere, you need to have that thinking, what is happening in your country. So when you talk of hot flashes, we know it's a feeling of warmth. Look at that in between lines, in bracket, in 85% of women. This is what we cut and paste whenever we talk of hot flashes. That's not true really. But this one single sentence is cut and pasted everywhere. And then we talk of hot flashes, we give this. So that's not true. Increase blood flow to chest, neck and face. This is from my own talk somewhere else. But the people who really need the medicine are the ones who are standing in front of a fan, in front of an AC, and everywhere. The hot flash is just not going away. They can't work, they can't do anything. Those are the ones who need. And that is what we are really talking about. And when we go to a conference abroad, they will ask you, what is your Indian incidence? And we have to put your head down, because we really don't have Indian incidences. And even the representatives come and push their medicines in front of you. We don't know how far we need it in our practice. So this study is definitely relevant, because we need to know what is the incidence in our country. The study population was 40 to 60, and the All India study shows that the incidence of hot flashes is only 37.6. And in South India, mostly from Madurai and Calicut, and some from Thrissur, of course, and Bangalore, the incidence is only 22%. The same in North, that's because it came from Jammu and Chandigarh, cold places. The incidence is only 27. Nothing near 85 that is quoted everywhere. Central came from Raipur, that's giving 65%, I don't know how that came. West is Jaipur mostly, that's 56 because it's a hot place. East, very few participants anyway. So it's a skewed data, actually speaking. But so overall 37.5, and you can say South and North is practically 22, and that's why even Revati madam was saying, Shobana, what is this? What is happening? I'm not getting any percentage. What is happening? What is happening? She's calling me up on the phone and asking. But it is true. What is true is true. We have to accept that we are reading wrong data on the net. Now, another thing that we always, whenever PCOD patients come to us, we tell them, you reduce your weight and you will be all right. So we are like, the onus of not knowing how to treat PCOD is gone. If you are having menopause, you reduce your weight, you will be all right. So everything is all dependent on how many calories you put on. And so the fat tissue, the proponents of this theory, whenever the data comes in your study, you try to find a reason for that. And so some studies, they found that the data is higher in obese people. So they found a reason for that. They said fat tissue is preventing heat dissipation. Therefore, what happens? All that heat collects in your body and makes you have hot flashes. So fat people, please reduce your weight. All your menopause symptoms will go off. Is it true? We have to find out. There are other people, They are finding that the thin people have more hot flashes. And why are they saying? all these fat people have fat. The fat contains P4450 enzyme, and they will convert androgen to estrogen, so more supply of estrogens. So you are getting less hot flashes in obese women. So two different studies giving two different explanations for. So what is this study, particular study from me, Revati madam and rest of India we had? Normal weight people have highest number of hot flashes. Less in thin people, but the normal weight people is 46.5. And overweight plus obese together is only 50%. It's almost equal to normal weight, so it's definitely not higher in obese, not higher in overweight alone, but if you are little above the normal, maybe a marginally, statistically insignificant amount of incidence is increased in the overweight people. Definitely it is much less in underweight people, but how many of us are underweight in that age group? Not even Shiny Abraham or all the sports women, they're all fat by the time they grow age. So that is a minute microscopic minority, and we don't have to really talk for them. So most of us are in the obese or overweight categories. So there the incidence of hot flash is not higher than the people who have been exercising and eating properly and maintaining their weight, like some of our dancers here and all those people. So yes, overall incidence is 37, but you can manage your hot flashes in quarter of them. You can't manage in 10.6 of moderate. You can't definitely manage in 2.23%. Those are the ones where you really need to know one after another, this medicine, that medicine, this medicine, that doctor to doctor running is only 2.23%, be happy. Not running to doctor, but each doctor doesn't know what to do is only moderate incidence. No doctor needed, or doctor needs to give only lifestyle modification is mild, 1 in 4. So definitely this conference is all about lifestyle modification. The speaker before me, the speaker after me, speakers around me, all the talks are on lifestyle modifications, and definitely that's what is necessary. Not all the symposia on MHT, because that is very less. Out of 37.5, even then quarter of them are mild and very few are severe. So that is where the emphasis should be, not much on emphasis, this thing. And a menopause conference just like this one should emphasize on other morbidities, like whether the gynecologist can come up on the stage without holding her hand, whether she can run. Lakshmi was telling me, run up. And like she thinks like I'm quite young, so she wants me to run. Yeah, I am, yeah. Compared to you, definitely. Anyway, so the point is other morbidities needs to be addressed, because it is after all a multidisciplinary organization. We should not be just talking about hot flashes and things like that. And we are talking about sarcopenia, and the sessions on those things need more emphasis, and we have to stray away from hot flashes, because definitely that's not the end of the incidence. Pan-India is not saying that that is the only thing that is there in a menopausal woman. And of course, MHT can't be forgotten, because we are the only ones who are going to talk about it and get the fear out of that, because 10% of moderate people and 2% of the severe people, they definitely need MHT, and we have to raise awareness of that. It cannot be forgotten, but it cannot take 50% of a conference in menopause. Yes, hysterectomy does increase the incidence of hot flashes, even severe hot flashes, with or without removal of ovaries. That is the sad part of it. I never used to think like that. 66 women of 116 total hysterectomies women had hot flashes. That is 56.88% against the overall incidence of 37. That means definitely the incidence is increased in hysterectomized patients. And out of them, 27 had severe hot flashes. The ones who have hot flashes, that same ratio doesn't apply. 1/4 are not having anything and only 2% are having severe. It's not like that. In hysterectomized patients, the hot flashes that come are definitely more severe. Therefore, you can't wish away the hysterectomy. And 23.27% of severe hot flashes as against 2 times, that means practically 10 times more people are having severe hot flashes when they are hysterectomized. So that does increase the incidence of hot flashes, that is definite. I always tell my patients, I am a good girl, I won't remove your ovaries, whatever your age is. I like, even if you're 60, there is androgen production from the ovary. That we always try to theorize everything, no? Whatever we like, whatever we think we are right, and we try to theorize. Androgen is converted to estrogen, so you will have enough estrogen till you are 90, not 90 of course, but we try to preserve the ovaries, so you are okay with me, because as a surgeon, I will preserve your ovaries, so you are happy, you won't have hot flashes. No, madam. Out of 116 women with hysterectomy, 666 had hot flashes. But out of that, only 40 people we could get the data. The data collection was little skewed in this meeting in this study. Out of the 40 where we had data, 30 had their ovaries removed, which is 1/3 more. But 10 had their ovaries preserved. So that data is higher in the women who had their ovaries removed, but even if the ovaries are preserved, definitely all that data does apply to them also, because somewhere the vascularity is compromised. When a patient is bleeding from such a large 1 kilo fibroid, you are not going to sit and worry about her ovaries. You are going to worry about your patient's life. You can't compromise. When you are worried about the ureter, you have to clamp somewhere nearer and somewhere nearer the ovaries, and all these things play on your minds, and therefore definitely we do compromise on the vascularity of the uterus, and therefore yes, hysterectomy has to be avoided in small cases wherever possible, because you don't want to have an irritating patient coming to you again and again. You should not be removing the uterus. But if you do remove the uterus, you have to tell her, yes, there is an incidence of increased hot flashes if necessary. You can tell her after the hysterectomy if you want, not before. But yes, there is no data for the remaining, and let me tell you why that happened, because there was a need to get data for statistical significance. If I ask private hospitals to give me data, they don't have enough data. If I go to medical colleges to get me data, they go and give the data collection to their registrars or their students or whoever does it, and they are not really sincere all over India. One place I had to reject 200 cases, absolutely 200 cases. Another place, I'm telling you, most of them said there is no hot flashes. The place where I'd get no hot flashes with 200 was where the patients filled the form. Can you imagine a form which is asking whether ovaries are removed, whether hysterectomy has been done, how many years before you have done your hysterectomy, whether you have your menstrual history, such a long form, and the patient is being filling the form. You can't help it. You try to find out, investigators from all over India, how to find sincere people who will have sincere students and who will do it sincerely is not very easy for a primary investigator sitting and conducting a study all over India. And another study has been conducted for a FHS study. The same year I could conduct that second study. That was the two highlights of my, people keep talking about my seminars or webinars, but my thought is that I conducted two large Indian studies. The second one, they gave money, 16 lakhs. We gave all the money to the people to collect the reports, and they were given everything, still they did not give adequate data, and somebody who is as high as Sudha Sharma, they were finding it frustrating. Shobana, the reports are not there, how can I give you statistics? So this is the problem. Even if you are good at the top, even if you are good at the bottom, in between somewhere some hitches are there. All India study is not as easy as All America study, where everything is insurance driven. So we have to handle whatever we have, and so the need to get correct and uniform data for statistical calculation was very difficult, and so you have to forgive me for not getting me correct, accurate data on how many years after ovary. Now this paper I'm publishing, talking in Malaysia, one question they asked me is, tell me how many years after hysterectomy you got the hot flashes. I'm not even getting data whether the ovary is removed or not. How will I give you data on how long back the ovary was removed? So that is difficult in India. Now another fallout is, incidence of hysterectomy in India is 7.84. Quoting this incidence, a lot of people were saying India is the capital of hysterectomy. How can you quote this and say that India is the capital of hysterectomy? Because in developed nations, USA and Australia, the incidence is 17 to 26%. So just to say hysterectomy is higher in India is probably a little outdated. I mean, it's not really correct, but all those seminars of Save the Uterus campaign has definitely helped and should be continuing. Instead, you can't do away with menstruating women. Menstruating women also having 30% incidence, just almost as near as a 37% full incidence. So menstruating or non-menstruating perimenopause is associated with hot flashes, and that's a hard reality, and you have to look for it even in patients who are coming with difficulty in this thing. Now, there are concomitant symptoms, and that's where you have to catch your hot flashes. The night sweats are increased, abdominal discomfort is increased. It is 361 in patient with hot flashes. It is only 143 in patients who are normal. Abdominal discomfort is 312 in hot flashes patients, only 172 in normal patients. Difficulty in getting sleep is higher, 352 in hot flashes and 175. So everything is higher in women with hot flashes. Therefore, if you have night sweats, you have to find out and look for hot flashes. And if you have difficulty in sleeping, just don't go and give them pills of clonazepam and give them idea of not looking at the TV till the late night and not increasing cortisol levels and all that. You have to find out if they've got hot flashes, because that can increase the incidence of sleeplessness, and that is one fallout of the study, that you have to treat them with estrogen if they are primary talkers about decreased sleep. Even then you have to look for hot flashes and then treat it. Abdominal discomfort. I had the pharmacy lady who was sitting in my house. She came and said, I've got chest discomfort and I've got abdominal discomfort. I do not have hot flashes. Should I give her estrogen? Should I not give her estrogen? All her ultrasound is normal, her ECG is normal, everything is normal. She's a widow, her husband is dead, her son is dead. Is it psychological? And I should send her directly to my husband. She will not like that. But the point is, definitely it is higher in abdominal discomfort, and you have to take a detailed history. But the data collection is such that all the 5 things are kept there, and they're asking, do you have abdominal discomfort? Do you have hot flashes? Do you have chest discomfort? Something like that. And there are a lot of people where only abdominal discomfort is there and there is no hot flashes. Will you consider that as vasomotor symptom at all? So that data collection is also a little skewed in this, but when a patient comes like this in real life, I really don't know what to tell them, because there is nothing else, and should I put her on little bit estrogen or even phytoestrogen or something like that is a moot, I mean, it's a difficult question to answer. Now I had given a public talk on hot flashes, and I had said that chest discomfort is a common complaint seen in women in perimenopausal, and in addition to doing your ECG and everything, you have to ask if they've got vasomotor symptoms, and if that is there, you have to give MHT. Now, one person sitting in the audience came and asked me, Madam, how will you distinguish between the chest discomfort of hot flashes, chest discomfort, and the discomfort that is coming from heart disease? I really don't know. In my study, there are a lot of patients with chest discomfort who do not have hot flashes. So I just told her, if it comes with hot flashes, I will treat it as hot flashes, chest discomfort. But in this particular study, because the data is where, I actually sat and counted. There are 51 women with chest discomfort who did not have hot flashes in the study of 1470 patients. So how do you consider them as vasomotor symptom? And they are obviously not having ECG problems, otherwise they wouldn't be on this study at all. They would be in some cardiologist OPD. But yes, this is a problem. We have to, we have to redo our question pattern, and maybe the future IMS people will have to find out a way out of this and get a data and get a formulation, CPG guidelines or whatever. This interesting thing came that Hindus have very few hot flashes. The majority of participants in this study are Hindus. 38% of Christians and 39% of Muslims have higher hot flashes incidence. That's very funny. Is it because of the increased red meat incidence in them? I really don't know. Because Japanese, we said they're all eating soya, that's why their incidence is less. What do you talk about the Hindus now? Even less in Sikhs. So why Hindus and Sikhs are having less hot flashes? Not all of them are vegetarian. Red meat, is it less in them? I really don't know whether it is cultural differences. I have no idea why this particular data came, but it's definitely not a small number, and the most of the participants are Hindus. So I don't know what explanation to give that. Marital incidents also, I am very funnily, married people and widows, they have less incidents. Divorced or separated and unmarried, both have very high incidence of hot flashes. Now, where is the correlation? I really don't know whether it is psychological, and I really don't know. Married people, let's say we would have been happy if we were not married, but at least you will have less hot flashes. So that is one thing you will be happy. So that is there. Employment, so there was not much difference, and actually, I really don't have much to talk about on this topic, so I am really finishing before time. And thank you for this patient listening. And the incidence of hot flash is 37.5, not much correlated with body mass index, lower incidence in Hindus. Incidence of hysterectomy in India is a healthy, this thing, we are not the capital of hysterectomy in the world. Thank you so much.